oxalase inhibitors appears to be an on-target effect of the drugs. And so it's not clear whether any of these hip stabilizers can be used safely on a chronic long-term basis to stimulate erythropoiesis in chronic kidney disease patients. Now, I should mention that roxadustat, vadadustat, and daprodustat are all approved for the treatment of anemia due to chronic kidney disease in Japan, with a warning about the increased risk of thromboembolism. But in Japan, at least, the medical authorities there have judged that the benefits outweigh the risks of these drugs, and they've been approved for the treatment of anemia in chronic kidney disease patients. Well, next I'd like to turn my attention to another kidney disease, and this is a hereditary cancer syndrome called the von Hippel-Lindau syndrome, in which affected individuals are at greatly increased risk for the development of clear cell renal carcinoma. And you can see how it gets its name. On H&E sections, the cytoplasm stains poorly with the dyes. And we've stained this in addition with an antibody against HIF-1 alpha. And you can see that every one of the tumor cell nuclei is staining intensely with the antibody. And if we take these tumor cells out of the tumor and put them into culture and culture them under high or low oxygen conditions, we find that there are very high levels of HIF-1 alpha and HIF-2 alpha regardless of the oxygen concentration. If we return a wild-type copy of the VHL gene into these cells, we restore the oxygen-dependent degradation of HIF-1 alpha and HIF-2 alpha. And what's been shown is that while these cells will form tumors if injected into immunodeficient mice, these cells will not. So it's the dysregulated expression of HIF-1 alpha and HIF-1 beta that results in the triggering the development of cancer. So these individuals have one VHL gene mutated in the germline, and the second gene is mutated or inactivated or deleted in kidney cells. Those cells then completely lack VHL. They are unable to degrade HIF-1 alpha and HIF-2 alpha under normoxic conditions, and that drives the development of cancer. And of course, when the cancer is restricted to the kidney, the surgeons can effect a cure. But when the cancer has spread beyond the kidney, the prognosis is very poor, with a 5-year survival of less than 12% for patients with metastatic renal cell carcinoma. And so it was really striking when this report appeared of a drug that's now called belzutifan. And this drug, which was developed by a small biotech in Dallas called Peloton, can bind to HIF-2 alpha, and its binding to HIF-2 alpha results in a structural change that prevents HIF-2 alpha from dimerizing with HIF-1 beta. As a result, there's no functional HIF-2 alpha protein within cells treated with belzutifan. And it turns out that during progression of kidney cancer, in many cases, the HIF-1 alpha expression is lost, and the cancer is driven solely by HIF-2 alpha. So inhibiting HIF-2 alpha is sufficient to inhibit HIF activity. And in this phase 1 trial, it was quite remarkable the number of patients, and these are patients with advanced cancer who have failed all existing treatments. There were many patients with partial responses and even more patients with stable disease, for a disease control rate of 80%, which was utterly remarkable in a phase 1 trial. And this drug was approved by the FDA for the treatment of renal cell carcinoma and other tumors in patients with von Hippel-Lindau syndrome last year. Well, there's one side effect of the drug that occurs in about 90% of the patients, and it's an on-target effect. And what would you think that might be? Well, yes, it's anemia, because, again, HIF2 controls EPO production, and the inhibition of HIF2 systemically, because this drug is given systemically to patients with metastatic disease, results in an EPO-deficient anemia. However, the anemia is really only severe enough to require treatment in about 15% of patients who take the drug. So this is really the first drug to be approved in the United States that targets the HIFs therapeutically. Well, in contrast to the renal cell carcinomas in von Hippel-Lindau syndrome, which are really being driven by the genetic alteration, the expression of HIFs in many cancers is driven by the presence of intratumoral hypoxia. So this is a picture of an advanced human cancer, and we've stained this with an antibody against HIF1 alpha, and this brown staining you can see again is intensely lighting up these cancer cell nuclei. But let's start with these white areas, which are areas of necrosis, and these are areas where the cancer cells have died because they're too far away from a blood vessel to get oxygen. In other words, the oxygen has been consumed by all the intervening cells, and by the time you get out here, there's no oxygen available, and these cells have died. But then you notice that these cells with the very high HIF1 alpha are the viable cells that are furthest away from the blood vessel. Okay, so this makes perfect sense that the hypoxia here is severe enough to turn on HIF1 alpha and HIF2 alpha levels, but not severe enough to kill the cancer cells. And what's been found is that increased HIF1 alpha expression like this in the primary tumor biopsy is associated with decreased patient survival in many solid tumors. And this just shows a list of various solid tumors and studies which have shown by immunohistochemistry that high HIF1 alpha in the diagnostic biopsy is associated with increased patient mortality. And some of these involve subsets of patients, others involve unselected patient populations. But in all of these studies, high HIF1 alpha equals increased risk of patient mortality. And the reason for that is that we know of genes that are activated by the HIFs that contribute to every critical aspect of cancer biology. So we were interested, starting quite a few years ago, in identifying drugs that could inhibit HIF activity that we might use first in animal models to judge the effects of HIF inhibition in animals with tumors. And so this is one of the first drugs that we found that inhibits HIF activity. It's called acroflavin. It acts by binding to both HIF1 alpha and HIF2 alpha and blocking their dimerization with HIF1 beta. And here we've injected human prostate cancer cells into immunodeficient mice, allowed the tumors to grow to a volume of 100 cubic millimeters, and then started treatment with acroflavin by intraperitoneal injection on a daily basis. And you can see that immediately upon starting the treatment, the growth of the tumor is arrested compared to tumors in vehicle-treated animals. And then after 2 weeks of treatment, we we euthanized the animals, harvested the tumor, and measured the expression of HIF target genes encoding angiogenic growth factors and proteins required for glucose metabolism. And you can see in all cases the expression of these RNAs was significantly inhibited by treatment with acroflavin. We also analyzed sections of the tumors for blood vessels by staining with antibodies against CD31, which is expressed by vascular endothelial cells, and smooth muscle actin, which is expressed by vascular pericytes and smooth muscle cells. And you can see in the vehicle-treated tumors that there are large blood vessels, and in the tumors from the acroflavin-treated mice, the blood vessels are here, but they're very small. So the perfusion of the tumor is greatly reduced by this reduction in vessel area. So acroflavin can inhibit HIF activity. It inhibits expression of angiogenic growth factors. It blocks angiogenesis, and it blocks tumor growth. Another drug that we identified that inhibits HIF activity is this one, digoxin. And digoxin works by inhibiting the accumulation of HIF-1 alpha and to a lesser extent HIF-2 alpha protein in hypoxic cells. So in this case, we were studying a mouse model of triple-negative breast cancer, in which we injected human triple-negative breast cancer cells into the mammary fat pad of immunodeficient mice. And if we treated those mice with saline, you can see the primary tumors grew very rapidly. They metastasized to the lymph node and to the lungs. But if we treated with digoxin, as soon as the tumor became palpable, you can see that primary tumor growth was significantly inhibited, as was lymph node metastasis and metastasis to the lungs. And we went on to study the mechanisms by which HIFs promote the metastasis of breast cancer cells to the lungs. And you can see we did a fairly deep dive on this, and we deconvoluted the process of metastasis into discrete steps, and then identified specific HIF target genes that were required for each of these steps. And most recently, we focused on the ways in which the expression of the HIFs allows cancer cells to evade the immune system. In this study, in triple-negative breast cancer, we found that when triple-negative breast cancers were subjected to hypoxia, that the HIFs increased the expression of PD-L1. And you may know that this is a cell surface protein that acts by interacting with a protein on the surface of CD8 positive T cells and natural killer cells called PD-1. And when PD-L1 ligates PD-1, this triggers the inability of these cells to mount an anti-tumor response, a so-called exhaustion phenotype. But there are, of course, antibodies that are directed against PD-L1 or PD-1 that can block this interaction. And in some patients, treatment with these antibodies has dramatic effects in terms of reactivating the immune system to the point that it can eliminate the cancer cells from the body. But in the majority of cancer patients, these treatments are not effective. Why is that? Well, in the case of the triple-negative breast cancer cells, the HIFs also turn on the expression of another cell surface protein called CD73. And this is actually an enzyme that converts AMP into adenosine. And adenosine binds to cognate receptors on CD8 positive T cells and natural killer cells and induces the same exhaustion phenotype that is induced by the ligation of PD-1. So you can appreciate that if you block this interaction, if the cancer cells are producing lots of adenosine, these immune cells will remain exhausted and unable to mount an anti-tumor response. So that there are then multiple mechanisms by which the HIFs can inactivate adaptive immunity. What about innate immunity? In triple-negative breast cancer cells, the HIFs also turn on the expression of another cell surface protein called CD47. And this is the so-called don't eat me signal, because it can bind to a protein on the surface of macrophages called SIRP-alpha and block the ability of the macrophages to phagocytose cancer cells. So and we showed that if we expose triple-negative breast cancer cells to hypoxia, we could identify individual cells that expressed all three of these proteins and therefore were resistant to both innate and adaptive immunity. Well, we've been interested in targeting the HIFs for therapy in hepatocellular carcinoma, which is the third leading cause of cancer death worldwide, and it's the most rapidly growing cancer diagnosis in the U.S. over the last 2 decades, because fatty liver predisposes to hepatocellular carcinoma, and obesity results in the development of fatty liver. Again, if the tumor is confined to the liver, the surgeons can eliminate it. But when the tumor has metastasized beyond the liver, again, the diagnosis, at the time of diagnosis, the prognosis is very poor, again, with a 5-year survival of less than 15%. And the first approved drugs for advanced hepatocellular carcinoma, meaning extending beyond the liver, were mixed kinase inhibitors that provide only modest survival benefit with very low response rates, high toxicity, and frequent development of resistance. The immuno-oncology drugs, such as the anti-PD-1 antibody nivolumab, were tested, and this drug was actually granted FDA approval based on phase 2 trial data, but phase 3 trial of nivolumab versus sorafenib as first line did not meet the primary overall survival endpoint. A phase 3 trial of another anti-PD-1 antibody, pembrolizumab, versus placebo as second line was also negative. And then the combination of an anti-PD-1 antibody with an anti-CTLA-4 antibody, ipilimumab, resulted in a 33% response rate. And as you may know, when you combine these two drugs, there's an increased risk of adverse effects due to the immune system damaging normal tissue in the body. Well, studies have shown that HIF-1 alpha expression is increased in the primary tumor biopsy in about 60% of cases of hepatocellular carcinoma, and the increased HIF-1 alpha expression is associated with decreased disease-free and overall survival and an increased risk of recurrence after radiation or surgery. So we wanted to identify novel inhibitors of HIF-1. Acroflavin works very well in animals, but it's a DNA intercalating agent. It causes DNA damage in addition to binding to the HIFs, and so it's not really appropriate for chronic use. Digoxin has a very narrow therapeutic window in humans because it inhibits the sodium-potassium ATPase and can cause arrhythmias. And in mice, the sodium-potassium ATPase is resistant to digoxin, and so we can use higher concentrations that would not be tolerated in humans. So we went to the NCI Cell Miner database, which contains gene expression data on over 20,000 mRNAs in 60 human cancer cell lines that have been exposed to over 20,000 different chemical compounds. And we queried the database for chemical compounds that induce changes in gene expression that were similar to those induced by acroflavin, but were chemical compounds whose structure was unrelated to acroflavin or to digoxin. And then we purchased these compounds and we tested them in a HIP-1-dependent cell-based reporter assay. We identified a lead compound. We synthesized over 200 analogs and screened them. We found several dozen compounds that inhibited HIF activity. It inhibited the expression of HIF target genes in hepatocellular carcinoma cells exposed to hypoxia with a low micromolar IC50. And this is the drug that we carried on to animal studies. And you can see that it's a bis-bromo indole thiazole compound. And you can see that in a cell-based reporter assay, that there's, when we expose these HEP3B liver cancer cells to hypoxia, HIF1 binds to the firefly luciferase reporter and increases the expression of firefly luciferase relative to ranelloluciferase. If we treat with 5 micromolar 32-134D, you can see that we markedly inhibit the induction of reporter gene expression. And we can also look at the expression of endogenous HIF target genes. CA9 is a HIF1 gene, so it's only activated by HIF1 in HEP3B cells. And you can see that both 32-134D and a related compound, 33063, were able to very potently inhibit CA9 expression induced by hypoxia at very low micromolar concentrations, whereas a drug that is very closely related to belzutifan had no effect, because this compound, like belzutifan, only inhibits HIF2. EPO is a HIF2 regulated gene in HEP3B cells, and you can see that these novel HIF inhibitors can inhibit EPO expression as potently as the HIF2 selective compound PT2385. Well, to get a more complete idea of the effect of 32-134D, we exposed HEP3B cells to hypoxia in the presence of 32-134D or a vehicle. And we found that there were over 3,000 genes induced by hypoxia in the HEP3B cells, and 86% of those genes were inhibited by 32-134D. On the other hand, there were over 4,000 genes that were inhibited by the compound under hypoxic conditions, and 71% of those were hypoxia-induced genes. So this drug is quite selective for inhibiting the HIFs and inhibiting HIF-dependent gene expression in hypoxic cells. We then injected the HEP3B cells subcutaneously into immunodeficient mice, allowed tumors to grow to about 150 cubic millimeters, and then started treatment with saline or increasing concentrations of 32-134D, 20, 40, or 80 milligrams per kilogram per day by intraperitoneal injection. And you can see that there was a dose-dependent inhibition of tumor growth, and we achieved a maximum therapeutic effect at a dose of 40 milligrams per kilogram per day. You can see the drug had no effect on mouse body weight. It had no effect on the appearance or behavior of the mice. And after treatment of the mice for 17 days, we isolated the tumors and analyzed the expression of HIF1 alpha and HIF2 alpha by immunoblot assay. And you can see that these proteins are highly expressed in the tumors from vehicle-treated mice and are almost completely absent from tumors of drug-treated mice. So this drug can induce the degradation of both HIF1 alpha and HIF2 alpha in vivo. Well, when we took out the tumors, we noticed first that they were smaller and weighed less, but the appearance was different. You can see the tumor is much paler when it was isolated from a drug-treated animal compared to animals treated with vehicle. And so we performed immunohistochemistry with an antibody against CD31, and you can see these large blood vessels in the vehicle-treated tumor. And again, in the tumor from the mice treated with 32134D, the blood vessels are here, but they're very reduced in size. So there's a tremendous decrease in the vessel area within the section, which of course would translate into a tremendous decrease in perfusion of the tumor tissue. We looked at the expression of a whole series of mRNAs encoding angiogenic growth factors and cytokines in the tumor tissue, and you can see that the expression of all of these angiogenic factors was inhibited by treatment with 32134D. We also looked in tumor lysates for the actual protein expression, and we could demonstrate by ELISA significant decreases in the concentrations of VEGF, stromal-derived factor 1, erythropoietin, and stem cell factor or KIT ligand. So 32134D can potently inhibit tumor growth and angiogenesis. We then went on to a mouse model of hepatocellular carcinoma in which we injected HEPA-16 hepatocellular carcinoma cells into syngeneic C57L mice. So these mice have an intact, adaptive, and innate immune system. And you can see that when the tumors were treated with a isotype control antibody, the tumors grew very rapidly. The animals needed to be euthanized. If we treated with anti-PD-1 antibody, 5 doses every 3 days, we could reduce tumor growth and in some cases cause tumor eradication. But you can see in some of the mice, when the treatment was stopped, the tumors reappeared. If we treated with vehicle, of course, we got rapid tumor growth. But if we treated with 32134D at 40 milligrams per kilogram per day, you can see that tumor growth was markedly inhibited, and we were able to eradicate the tumors completely in a third of the mice. When we combined these two therapies, the effect was really dramatic. Now we had tumor eradication in 2/3 of the mice. So if we could obviously translate this to the clinic, that would be a really dramatic improvement in the care of patients with liver cancer. So of course we're interested in trying to understand how does the HIF inhibitor increase the response to anti-PD-1 therapy. And so we looked at the presence of immune cells within these tumors. And what we found is that in tumors from vehicle-treated mice, there was a significant increase in CD8 positive T cells and natural killer cells. So these are the cells that mediate anti-tumor immunity, both adaptive and innate anti-tumor immunity. These are the cells that must be present for anti-PD-1 to be active because these are the target cells for the drug. On the flip side, we found that tumor-associated macrophages and myeloid-derived suppressor cells were at significantly decreased frequency within the tumor, and these are cells that suppress anti-tumor immunity and mediate resistance to anti-PD-1 therapy. So you can see how the treatment with the drug switched the tumor from an immunosuppressive microenvironment to a microenvironment with anti-tumor immunity that could then be augmented by anti-PD-1 therapy. So next the question was, what were the genes that whose expression was modulated that resulted in the change in these tumor cell populations. And so we performed a PCR array looking at the expression of a whole series of interleukins, chemokines, and cytokines at the RNA level. And all of the RNAs in this quadrant were significantly reduced in their expression in tumors from animals treated with 32134D as compared to tumors treated with vehicle. And you can see here a number of known immunosuppressive interleukins like interleukin 10, VEGF, and many other of these interleukins and cytokines that are responsible for creating an immunosuppressive environment. In this quadrant are the RNAs whose expression was significantly increased in tumors from mice treated with the HIF inhibitor. And here you can see CXCL9 and CXCL10. These are the two chemokines that are responsible for the recruitment of CD8 positive T cells and natural killer cells to the tumor. And then interferon gamma was also increased, and this is a measure of anti-tumor immunity. We then wanted to confirm these results at the level of protein expression, and so we performed ELISA assays on tumor lysates, and we saw significant increases in the levels of proteins such as CXCL9 and CXCL10, which are required for anti-tumor immunity, and significant decreases in the expression of VEGF, IL-10, and other proteins that mediate immunosuppression. We also looked to see whether treatment with 32134D had any effect on red blood cell production or EPO levels, and the answer was no, it did not. So it seems as though the drug is primarily active within the liver cancer cells and does not inhibit HIF activity, for example, in the kidney. So 32134D can induce the degradation of HIF1 alpha and HIF2 alpha. It can block the expression of angiogenic growth factors. It can convert an immunosuppressive tumor microenvironment to one favoring anti-tumor immunity. And it can sensitize hepatocellular carcinomas to anti-PD-1 therapy in mouse models. And we're, of course, hoping to take this drug to clinical trials as soon as we can. Well, I'll stop there. Salman is a really incredible postdoc in the lab who spearheaded the 32134D project. Thank you for your kind attention, and I'd be glad to answer any questions.
Thank you, Professor Gregg. Oh, it was a terrific lecture. It was amazing. We're very glad for that.
Thank you.
As I said before, I think it's the lecture, we don't have questions. So I'd like to thank you again in the name of the Brazilian Society of Pharmacology and Experimental Therapeutics. It was our privilege and honor to have you here giving this lecture. And I would like to invite our president to join us, the president of Brazilian Society of Pharmacology, Professor Marco.
He's just joining as a panelist. Just a second.
Okay, thank you very much. Marco?
Hello.
If you want to say some words to Professor Gregg.
Hello, Professor. Thank you very much for this brilliant lecture. It was really a great pleasure and privilege to have the opportunity to hear from your studies. It's a pity we have to do that conference virtually because of the uncertainties of the pandemic. But hopefully next year or in the near future, we can have the pleasure of having you with us in in the meeting of our society. Thank you very much.
Thank you, Marco, and thank you, Professor Gregg, again. So I think if Professor Gregg wants to stay with us, we are going to close our Congress and we have the closing ceremony now. Started the closing ceremony.
Okay. Gabi, could you please present our slides?
Yes, I can. Just a minute.
All right. So, can I start, Gabi?
Yes.
Good afternoon, everyone. I am delighted to welcome you to the closing session of this 54th Brazilian Congress of Pharmacology and Experimental Therapeutics. I hope you have enjoyed our annual meeting as much as I did. I would take this opportunity to give, particularly those from abroad, my special thank you to the contribution and for having attending this event of the authors of our society. And I look forward to meet you again next year, face to face, hopefully. From now on, I will speak in Portuguese then. Ok? Boa tarde a todos. Então, mais uma vez, é um prazer recebê-los aqui nesta cerimônia de encerramento do nosso 54º Congresso da Sociedade Brasileira de Farmacologia e Terapêutica Experimental. Eu vou iniciar, por favor, Gabriela, próximo slide, mostrando-lhes alguns dados, alguns números relativos ao nosso congresso. Nós tivemos 424 participantes este ano, com grande predominância feminina, 249 e 174 homens. Nós tivemos a participação de 22 estados brasileiros nesse evento, mais o Distrito Federal, e tivemos 36 participantes de 13 países do exterior. Nós tivemos a oportunidade de assistir 3 cursos ao longo do programa, 9 lectures, 12 simpósios, incluindo o JRV Award, 13 sessões em 2 dias de comunicações orais e posters, 2 mesas redondas e 95 speakers. Eu quero aqui aproveitar para agradecer a todos eles pela essa contribuição fantástica que deram para o êxito desse evento. O próximo, por favor. Então, aqui é só uma panorâmica rápida da distribuição por regiões, e a gente percebe essa concentração ainda na região Nordeste, Sul-Nordeste, mas já também com a presença marcante do Nordeste. Precisamos trabalhar, com certeza, ainda com mais força o Norte e Centro-Oeste para aumentar esse envolvimento, né? É um desafio e é extremamente importante e oportuno fazê-lo. Próximo slide, por favor. Então, aqui a distribuição, né, um pouco como eu já mostrei, dos diferentes estados, né, predominância em São Paulo, Rio de Janeiro, Rio Grande do Sul, Ceará, Paraíba, Santa Catarina, Paraná, Minas Gerais, representantes de Alagoas, Rio Grande do Norte, Bahia, vários outros representantes de estados brasileiros aí. E 36 participantes do exterior. Eu vou agora passar a palavra para a Jamile Ferro, que é a coordenadora da SBERT Jovem, que fará a apresentação do Second Cultural Competition for Scientific Dissemination. Jamile, por favor.
Boa tarde a todos. Obrigada, Marco. Eu gostaria de agradecer ao apoio da SBERT, da diretoria da SBERT, né, e ao suporte da comunicação, a Gabriela com a NUI, por todo o apoio e suporte para a realização desta atividade, e um agradecimento especial a todos os participantes que submeteram seu material, né, para que a gente pudesse continuar com essa missão, com essa atividade de divulgação científica. Tá? Próximo, por favor. Então, essa já é a segunda edição do concurso de divulgação científica da SBERT Jovem. Nós, além de promover a divulgação, né, de conhecimentos voltados para a farmacologia, a gente pretende ampliar o acesso por diferentes pessoas com diferentes tipos de dificuldade, por exemplo, aumentando a acessibilidade do material. Então, os materiais que foram submetidos ao concurso do ano passado, eles já foram traduzidos para Libras e estão disponíveis no canal do YouTube da SBERT, e esse material de segunda edição também passará por esse mesmo processo de acessibilidade. Próximo, por favor. Nós tivemos 4 vídeos que avançaram para a segunda etapa do concurso, né, a etapa de votação popular, onde a votação aconteceu pelo canal, pelo Facebook da SBERT e também pelo canal do YouTube da SBERT. E ao final dessa etapa, né, nós tivemos aí 2 categorias com representantes com materiais submetidos, as categorias de reposicionamento de fármacos e de simplificando conceitos em farmacologia. Então, no próximo slide, nós vamos conhecer o vencedor da categoria reposicionamento de fármacos, e aí vai o nosso parabéns e agradecimentos a Yasmin e colaboradores da UERJ pela submissão do trabalho, né, intitulado Como um fármaco desenvolvido para a osteoporose pode ajudar no tratamento de outras doenças. Parabéns a todos os autores do material. E a próxima categoria, simplificando conceitos em farmacologia, nós tivemos como material, vídeo vencedor, o vídeo intitulado Farmacobol, utilizando o futebol para explicar conceitos da farmacologia, sob a autoria de Isabelle Pierre de Oliveira e colaboradores da Universidade Federal Fluminense. E parabenizamos também aos autores dos vídeos intitulado Farmacologia dos Antioxidantes, né, por Viviano e colaboradores da Faculdade de Medicina de Ribeirão Preto, e a Aline Castro, pelo vídeo explicando a dependência química através de cigarros eletrônicos. Né? Todos os materiais são de excelente qualidade, de fácil compreensão e atenderam aos objetivos desse concurso. Né? Então, muito obrigada a todos e obrigada a SBERT pelo suporte, né? Pelo apoio para que a gente possa desenvolver essa atividade. Obrigada. Marco?
Ok, então, parabéns a todos os inscritos aí, parabéns a Jamile e a SBERT Jovem, mais uma vez, né, por essas atividades criativas que têm trazido uma grande motivação a mais para os nossos jovens, trainees, em pós-graduandos e pós-docs. Eu acho que isso precisa ser incentivado. Parabéns a todos vocês, parabéns a todos os que concorreram a esse prêmio. Os vídeos estavam fantásticos. Próximo, por favor. Então, aqui nós vamos seguir para os e-posters, os prêmios, aos destaques, né, das 2 sessões de pôsteres que tivemos na quarta e quinta-feira. Próximo, por favor. Na sessão de iniciação científica, para os estudantes de iniciação científica que participaram, né, dos e-posters, menção honrosa para Raquel Campitelli, Thaís Fernanda Dalfer, Elisa Piton, Cecília Pena Macário Kondak, Maria Cláudia dos Santos Bittencourt, Gustavo Pinho dos Santos, Melissa Garcia, Brena Freire, Juliana França, Mariana Conceição, Jaine Muniz Fernandes, Everlaine Leite, Camila Megumi Hirokawa e Petruska Pessoa. Parabéns a todos vocês. Próximo, por favor. Agora para os estudantes de mestrado, Tamires Petrucci, Edivaldo Souza Lara, Laís Gross, Beatriz Cezimin Gomes, Eric de Toledo Gomes, Nayara Ayako Satori, Antônio Rafael Silva, Cauê Oliveira, Laura Ben Olivo e Lucas Hassib. Próximo, por favor. Agora os estudantes de doutorado. Natália Ferreira de Oliveira, Eduarda Medeiros, Ana Maria Raimund, Matheus Medeiros, Isabela Zaidan, Patrícia Rodrigues, Jorge Luiz Dalazen, Maria Luísa Santos da Silva, Cauane Fabrício Moura, Larissa Gonzaga Santos Kiataki, Felipe Leonardo Fagundes, Raquel Rangel Silvares, Renan Pereira Lima, Marina Del Gobo e Graziela de Araújo Locke. Sim, pós-doc, Tatiana Paula Teixeira Ferreira. Eu vou pedir uma salva de palmas a todos os e-posters com menção honrosa nesse evento. É um pouco estranho, não é, a gente fazer essas homenagens assim online, mas isso vai mudar, com certeza. Próximo diapositivo. Então, agora nós vamos para a nossa sessão José Ribeiro do Vale. O JRV 2022 é o de número 24. Né? Então, é uma atividade muito importante para a gente, né? que é uma sessão que traz uma motivação para os mais jovens, aqueles que estão com interesse grande em desenvolver a carreira científica, a carreira em farmacologia. A gente tem o prazer e a honra de poder contar aí com o apoio e o suporte da Biolab Farmacêutica por, mais de 20 anos. Né? Então, o nosso agradecimento à Biolab, a gente espera poder continuar contando com o apoio deles no próximo ano e nos anos seguintes. Agora, eu vou... Gabi, eu acho que a gente tem um vídeo do CEO da Biolab que vai fazer uma mensagem para a gente.
Olá pessoal, meu nome é Marco Aurélio, eu sou farmacêutico e estou responsável por inovação e qualidade na Biolab. É com muita satisfação que estamos aqui mais um ano participando ativamente do Prêmio José Ribeiro do Vale em parceria com a SBFTE, uma entidade, uma sociedade séria e que apresenta sempre material de muito conteúdo científico. Então eu gostaria aqui de cumprimentar a todos os finalistas e também os seus orientadores, mas por que não cumprimentar a todos que enviaram os seus trabalhos? Eu tive acesso a alguns conteúdos e imagino que a tarefa da comissão julgadora não foi fácil. Mas como toda premiação, é necessário escolher alguns finalistas. Então, novamente, parabéns a todos vocês. E aproveitando, queria falar um pouquinho aqui da Biolab, que investe bastante em inovação e acredita também na capacidade do Brasil em produzir conteúdo científico de qualidade. Então fica aqui um convite para você, pesquisadora, para você, pesquisador, fazer acesso através do nosso site, acessar a página Fale Conosco e preencher lá um formulário, que certamente daremos um retorno para você. Muito obrigado e um abraço a todos.
A gente que agradece, Dr. Marco Aurélio Silva. É um prazer poder continuar com essa parceria com a Biolab. Então, agora chegou o grande momento, não é? Vamos anunciar o ranqueamento, não é? Todos os 5 selecionados finalistas do JRV 2022 devem estar aí super tranquilos, né, relaxados nesse momento. Posso imaginar o quanto. Eu, antes de iniciar o anúncio dos ganhadores do JRV 2022, eu quero muito agradecer à comissão científica, este ano brilhantemente conduzida pela professora Tereza Cristina Fidalgo, que fez a condução desses trabalhos, desde da seleção, né, dos 20 selecionados inicialmente. Eles selecionaram 5 e depois das apresentações de ontem, eles fizeram esse ranqueamento. Agradecer muito ao professor João Batista Calisto, do CIEMP, e o professor também Juan Saavedra, que fez a nossa conferência de abertura, Rocha Silva Memorial Lecture, e também contribuiu aqui para esse trabalho de seleção e ranqueamento desses 5 finalistas. Lembrando que tem um prêmio da Biolab de R$17 mil, e a gente então vai começar anunciando quem foi o 5º colocado do JRV 2022. Gabi, por favor. Aí está o 5º colocado, que vai levar R$1.000, desculpe, está aparecendo Flávia Santos aqui para mim, não é a Flávia Santos, é a 5ª colocada é a Julie Spat Pérez, ok? Parabéns, Julie, pela 5ª posição aqui nesse concurso. Vamos agora anunciar o 4º lugar, né, nesse JRV 2022. Por favor, Gabi. Então, aí, 4º colocado foi o Viviano Neves, ok? Parabéns ao Viviano e seus colaboradores, seu orientador, ok? R$1.000, 4º lugar. Agora, 3º lugar. Gabi, por favor. Aurilene Gomes Cajado. da Federal University of Ceará, Universidade Federal do Ceará, UFC, ok? Aurilene, terceiro lugar, você vai receber R$ 2.000. E nossos cumprimentos também ao seu orientador, Roberto César Pereira Lima Júnior. Muito obrigado. Parabéns, muito obrigado pela participação e parabéns. Vamos agora mostrar o segundo colocado do JRV, Thiago Zaninelli. Parabéns, Thiago. Segundo lugar, R$ 3.000. Aqui, o orientador do segundo lugar, né, Valdiceu, vai também receber um prêmio de R$ 1.500. Parabéns também, Valdiceu, parabéns pelo trabalho, parabéns toda a equipe envolvida no estudo, ok? Finalmente, então, primeiro lugar, Fábio Bonifácio de Andrade, tá? O Fábio, Faculdade de Medicina de Ribeirão Preto, R$ 6.000 é o prêmio do Fábio, o orientador dele está aqui presente, e o que também vai ser premiado, né? R$ 2.500, então você já está incumbido, Thiago, de pagar o almoço da diretoria no próximo evento aí em Ribeirão Preto, no Pinguinhã. O que você achou da ideia? Parabéns ao Fábio, parabéns a todos os colaboradores do artigo, do estudo, ok? Então, eu acho que a gente pode agora, né, ir para o último slide. Nós estamos próximos do encerramento dessa sessão. Eu não poderia deixar de agradecer aqui os meus colegas da diretoria, né, o Thiago, a Tereza, a Flávia e o Richard, muito desde sempre, né, desde o início do ano, trabalhando pelo sucesso desse prêmio, juntamente com a Sandra, né, nossa secretária executiva, aí, mais de 30 anos de casa, ela entende mais de SBEF do que a gente mesmo. Então, muito obrigado a todos vocês. Vocês sabem que um evento desse tamanho não acontece assim, ele mobiliza muita gente. Eu queria agradecer muito, muito mesmo a todos aqueles que contribuíram direto ou indiretamente para o acontecimento desse evento, 54º evento da Sociedade Brasileira de Farmacologia e Terapêutica Experimental. Todos que contribuíram, analisando os abstracts, os chairs de sessão, os conferencistas, os nossos patrocinadores, todos eles, um grande abraço de agradecimento. A gente está aí muito na expectativa do evento do ano que vem. Nós vamos comemorar 55 anos de eventos da Sociedade Brasileira de Farmacologia e Terapêutica Experimental, e a gente está preparando aí uma reunião que seja memorável, né? Vai ser também o último ano dessa gestão. A gente quer agradecer a todos vocês, muito obrigado pela participação aqui, e eu gostaria de pedir aqui uma grande salva de palmas para a SBEF, que a gente continue acreditando na ciência brasileira, né, e que a gente continue acreditando nesse país. Boa tarde a todos, muito obrigado. Estou dando por encerrada o 54º Congresso da Sociedade Brasileira de Farmacologia e Terapêutica Experimental. Antes de terminar, a gente pode deixar vocês aí com esse slide que aponta para o estado de São Paulo, onde acontecerá o nosso próximo evento. Tá? Proximamente a gente vai divulgar o local precisamente. Ok? Muito obrigado a todos. Grande abraço. Até a próxima.